The 411 Live.
Where you can learn about issues that impact us every day. State of world, 411 Live.
Real people, real talk.
Made to help people in our community in every way. For your girl, 411 Live.
Hello, and welcome to the 411 Live, Real People, Real Talk. I'm Beverly Taylor. How are you holding up under the safer at home order? Are you keeping 6 feet away from everybody? How are you doing with the mask? Are you wearing it at the grocery store, or maybe even the gloves? You know, it kind of feels like we're in a movie, but we know it's necessary. As the number of coronavirus cases rise, as the deaths rise, we know it's necessary. The safeguards that we take could be saving our lives, could be saving the lives of our loved ones. You know, it also could be saving the lives of first responders who have to take care of us when we're sick. And if there are less of us who are sick, they're safer. Speaking of first responders, I have a special guest joining me now, Joshua Parish. Now, he is the Deputy Chief of Emergency Medical Services for the Milwaukee Fire Department. Joshua, thank you so much for joining us. Can you hear me okay?
Thanks for having me.
Oh, yes, absolutely. Now,
Perfect.
I realize that you are so busy, and I know you're in a situation right now. When's the last time you had a day off?
I don't think I've taken like a full day off for about a month now. So we've been full steam ahead with everything that we're doing here from both preparedness and a response standpoint.
Wow. Okay, I say that you are the Deputy Chief of Emergency Medical Services for the Fire Department. What does that entail? What does that mean?
Sure. So most time when people think of the fire department, they think of our ability to respond to fires, car accidents, and so on and so forth. But actually more than 80% of our total call volume actually involves medicine. So when individuals are having asthma attacks, heart attacks, diabetics, penetrating trauma, basically any emergency that you can think of falls under the caveat of the Milwaukee Fire Department's ability to render emergency medical services to individuals actually out in the community. So that includes, both our response capacities. So we operate between 12 and 14 advanced life support ambulances. All of our fire engines and fire trucks all have EMTs, and some of them have paramedics on them. We have a technology and logistics division. So, all of our defibrillators, all of our technology, all of our drug ordering. We have our own training center. So we actually train our own EMTs and work very closely with MATC to train our own paramedics as well. We have a quality control, quality insurance, section. We have accounts receivable and billing. We have research, and we also have a home care service as well. We actually send out some of our more skilled and trained paramedics to actually address some of the more critical health needs of high medical system utilizers in the community.
Wow, that's a lot. So you're the perfect person to talk to about coronavirus and its effect on the fire department. Tell me, I want to take you back when, we got word that things were happening in China. At what point or how early did you get in your head, this might be serious right here. This might affect our community?
I think it was pretty early. I'm kind of unique, and I also have a background in public health. Mm-hmm. So things like this, they always kind of ping my radar, and we always kind of think very critically about them. I think what was especially concerning was when we started seeing the mortality rates for the older individuals, and when that information actually, when that information became more and more public as the pandemic started to circle the globe, and we saw just how dramatically it was affecting older individuals. And also what the hibernation period was, the fact that an individual could actually spread the virus without actually being symptomatic is something that, we don't typically see we hadn't seen in some of our other, epidemics that were actually in other parts of the country or other parts of the world, rather. So just knowing that, that people could actually be participating in international travel and then come back to the United States, be asymptomatic, was have the capacity to spread the virus to others. That was probably the first big, first big warning sign. And then, I think Washington really put everybody on edge, saying how quickly it decimated, that area, that part of the country.
Yeah.
And then also saying what happened in New York and then really having it close in for both of the coasts. I think we were, we didn't see the effect on the United States with SARS or Middle Eastern respiratory syndrome that we saw with this. And I think that, once we saw just how thorough this virus was actually behaving, that actually kind of piqued everybody's alert level up a notch or two.
Yeah, I agree. And what happened in Washington, for me, that was the pivotal point where I thought, this is definitely serious. I have some numbers. As of April 17th, there were 2,055 cases of coronavirus in Milwaukee County and 120 deaths. Now there are probably more. Those numbers have probably increased. But Chief Deputy, I know with the coronavirus and what all's going on, it changes. It's like a new normal. So you guys are doing a lot of coordination with city and county fire departments. How is that working?
So we've always had a really close working relationship with the suburban departments that surround the city. Actually, our paramedic program is actually a county-based program. Mm-hmm. So while the paramedics actually work for the City of Milwaukee Fire Department, the training, education, and some of the quality control actually happens at the county level. So we've always, crossed borders and worked together in that facet. So this is really just an expansion of that pre-existing relationship, where we're really working to make sure that no individual community is overburdened, either from calls or from close contact with patients or from exposure to positive patients. So I mean, really, it was something that we were very preemptive about, and really seeking to make sure that that relationship was solidified and that it will work in response to this particular emergency.
So you already had the foundation. You just kind of expanded what was already existing.
Absolutely, yeah. Like I said, we've for the past several years been working together for shared responses for larger incidents. And then we had to run a pilot last year as well that was looking at some alternative responses here in the city. So really, being creative and being nimble was really, really a benefit to us as we, look to say, okay, how do we prepare regionally for what will be this additional onslaught in both patients and responsibilities and also new hazards that our responders will face as well.
So you have your normal 911 calls, medical calls, and now you've got the coronavirus thrown in, whereas people are saying, I was with somebody who now has been diagnosed, or I think I might have some symptoms. You're getting those kind of calls. So how are you kind of weeding those out to know, okay, we need to respond to this, but maybe not this?
That's a great question. So I know some EMS systems across the country have really, they really tried to separate what they should and shouldn't respond to. Here in Milwaukee, we haven't done that. None of our responses have changed, dramatically. We're still responding to every single 911 call that we receive. We have not refused service to anybody, because that's really the foundation of the service that we provide here. And that's also very necessary, especially here in the city. You have a lot of sections of the city and a lot of parts of our population that are medically underserved. So really, any part of, of rationing 911 service is really a disservice and, is an absolute non-starter, for us, here in the city. We have a very robust dispatch center. I think people are surprised at how high tech, medicine and the fire service has become. So a lot of that is computer aided. You still talk to a real person, but the questions that person is asking you, those all get triaged through a computer system. There's a variety of dispatch codes, and then there's additional screening questions that we can add. So in adding those screening questions, we're able to both identify positive cases in the community and also identify individuals that have symptomology through those questions, and then tailor that response to that specific individual's emergency at that time.
Okay, so I'm saying that Milwaukee County, from the April 17th numbers, 2,055 cases. Now, not all these people are calling 911, but there are a lot. I know there are 120 deaths. So the firefighters, the first responders are headed out there when they get these 911 calls and these people are sick. Some of them have the virus. How are our firefighters being protected? I know that there's protective gear. What about the ambulance? What's going on?
Great question. So one of the first things that we moved to was respiratory protection, for all members. So, keeping in mind that this is, while this is a respiratory virus, it's what we call droplet spread. So the actual spread of the virus comes from a person having respiratory droplets. They're either going to enter a person's mucous membrane, eyes, nose, mouth, or they're going to come in contact with a surface and then, touch their eyes, nose, or mouth. So, it really requires, having a thought about how do you actually contract, the virus, to really levy the appropriate protection for that. So, like I said, our members, are covering up their mucous membrane, regularly. So we're always going to wear safety glasses, and then we're always going to wear a respiratory protection that covers the eyes and the nose. And that's always going to extend to gloves as well, which is standard, for any medical encounter. When we are performing encounters that are going to bring up more matter from a person's respiratory tract. So if we're treating an asthmatic, if we're doing CPR, we're doing mass ventilations, if we're doing advanced airways, things that are going to actually bring more of those particles out of the lungs or give those particles more reach. Then we add another layer of protection, which will include a surgical gown. So we also have some specialized vehicles that we're using from confirmed cases. And then those individuals have an additional layer of protection. And not that the protection is additional. It's more so we have stuff that we can actually use over and over again. That's easier to decontaminate when we get done. So those units and those responders are actually optimized with that equipment and with those vehicles, which actually allows us to conserve PPE and allows us to get those vehicles back in service quicker because we can decontaminate those vehicles faster. Speaking
of PPE, the protective gear, how are you with this? You watch the news and you see that there is a short supply. People are having to reuse. Where is the fire department's? What's your status?
That's a great question. So, it's one of those things where that's a really tough question to answer when you kind of dig into it. And a lot of that, a lot of the shortages come from, supply shortages and really understanding better how those supply chains work. We have a countywide, logistics division that is making sure that we have, the PPE that we need to respond, on a daily basis. I think a lot of that uncertainty comes, from our standpoint is what will be the availability of that equipment, next month and the month after that and the month after that. As manufacturers starting to retool, there's also a global demand for the exact same thing. So everybody right now across the planet wants N95 masks. Everybody wants face shields. Everybody wants high-grade medical thermometers. Everybody wants gowns. Everybody wants respirators. And the challenging part is there's only so many companies that make these things. And in no way, shape, or form, were they prepared to make one for everybody on the planet. That wasn't a part of the plan, a year ago. Right. So it's really challenging for them to continually adjust to that and then to try to make sure that they have the ability to scale out not only just product, but also quality product. Because there are also things that are very, they're very tightly regulated. You don't want a malfunctioning thermometer. You want a thermometer that, that's accurate to within a 1/10 of a degree. So, it's not something that you can just make more from and make faster. Same thing with respiratory protection. You want something that that's built to only to not let certain size particles in. And if those things fail the testing at the factory, you really don't want that product. So when you start to understand how medical supply chain works and how sterile technique works, it adds an additional challenge, on to getting those supplies out really to the planet. There's 9 billion people on the planet. No corner of the planet will not be affected by this, except for the International Space Station. There's 4 people who, on the entire world who don't have to deal with it at all. But yes, I think that's the challenge here. is that, as this pandemic circles the globe and as it spreads to more and more countries and more really densely populated areas across the planet, the demand for those materials grows exponentially.
I think the first death in Milwaukee County was a retired firefighter. Mm-hmm. So I know, first responders are not immune to this. Do you know how many within your ranks have contracted coronavirus?
I know we have not released those numbers. So, for the privacy reasons and so on and so forth. I always tell our members and, individuals that part of the thing you have to keep in mind is that this is still officially a medical diagnosis. So all the medical, confidentiality rules still apply. Even though it's a reportable disease and it's it's the buzzword right now. We do still work very hard to protect the confidentiality of both all of our members and all of our patients. And that's gone into even, how we dispatch apparatus and so on and so forth. We still do so with that very real thought in mind that people's personal privacy and their medical privacy is still incredibly important to them.
Right.
Now I will say that this is something that, no one will remain unaffected by this. This is something that is, that will circle the globe. And what's interesting is that first individual that died, he was a retired firefighter, and I'll be honest, and I didn't know him. My daughter did, because it was actually one of her good friends from high school's dad. And as I talked to my mom, she's like, "Oh yeah," she's like, "We grew up together." It's like, we have pictures of us, playing together as kids. So I mean, really, that was kind of for our family, personally. That was when it hit home as my daughter's trying to console, she's trying to console her friend, as I'm talking to my mother, and she's realizing that, that she can't go to the funeral, that she can't visit with the family, that, even for like sending a card and, and making a phone call was as much, it was what she had to offer. And the heart really goes out to everybody's lives that have been disrupted by this, for all the major things that were always the things that you can count on doing regardless of anything happening, in any other, crisis you have, any other work thing you have, somebody close to you passes, you're going to go to the wake, you're going to go to the funeral, you're going to have a wedding, you're going to have a quinceañera, we're going to have birthday parties, all those things are now gone. And I think that, even for communities or personal groups that were late to adopt the safer at home, both here locally, even nationally, when those fatalities started hitting people that, that they knew, it became a very, very real thing very, very quickly.
It hit home. It did hit home. We have an uncomfortable new normal. With that said, we're going to take a brief break, and we'll come back and we will continue our conversation with Chief Deputy Josh Parish. Stay with us.
Human trafficking is a global issue that is happening locally. This is a problem that we cannot ignore.
Being so scared on that hotel bed and wish I had my mommy. Going back into that feeling of, man, what am I getting myself into?
She rests her head on the prison to which she's chained.
I'm standing there and I can't move. I can't go nowhere, I'm stuck.
Drug into this spider's web, and she can't untangle herself to freedom.
Him telling me how pretty I am and what I can do to trick guys out of money and what I need to do and how much money I need to bring back, and him making me change into different lingeries to take pictures of me to put me on Craigslist. Now I'm a product to be sold.
Beneath this ground we walk is a hell of movement in a forced direction. Gridlocked, traffic lights, sex, currency, bodies, stock, fear, monopolized, auction, blocks.
Another John, he come another one, and just being sold over and over and over and over.
Minds groomed to be immune to pain.
And you used to it, and you just lay there.
Numb, desensitized, innocence, drained,
I went from that scared little girl, from in foster care, from being molested by my stepbrother, by my foster brother, till to being a lonely little girl stuck in a house, so scared with my mother, to being trafficked.
Welcome back to the 411 Live, Real People, Real Talk. We are talking with Chief Deputy Joshua Parish. He's with the Milwaukee Fire Department. We are, of course, talking about the coronavirus and its impact on the fire department and first responders. Josh, I wanted to get into something else that is, disturbing to me. The numbers in the African American community with this coronavirus. I was looking at some stats, and it said African Americans make up 26% of Milwaukee County's population, but have accounted for 61% of the coronavirus deaths. And it seems like when we, as African Americans, get the virus, we are more likely or at a higher risk of dying from it than some of the other races. Is that what you're seeing?
Yeah, I mean, well, strictly from a number standpoint, absolutely. I know that we are also watching what we call our out-of-hospital cardiac arrest. It's actually when somebody, when somebody dies in the home or outside of the hospital setting. Normally, people will call 911 and we'll respond to those. But yeah, I mean, just looking at the numbers and the rates, and we have a lot of the same information that you have. We are absolutely seeing that, both on the mortality end and also on the actual contraction of new cases. And there's a lot of, emerging, I can't even say literature, like systems of belief about where that comes from. And a lot of it is well-founded, both, here locally and nationally. The prevalence of some of those comorbidities, hypertension, congestive obstructive pulmonary disorder, COPD. I very rarely say that all the way out. CHF, high blood pressure, diabetes, people who are immunocompromised. So individuals that either have an autoimmune disease already, or who have something going on that their immune system is compromised, like they're being treated for cancer or something like that. So those conditions are historically higher in communities of color, and they're also not as well managed in communities of color. So for a disease that attacks and kills people with those conditions more readily, a lot of that is what we're saying. And I really got to applaud Dr. Fauci for pointing out that, hey, we've seen disparate incidence of disease, prevalence of disease, and mortality in African American communities. For years, it's well established in the medical literature. And we now have a national spotlight on us. Not one of, but the most expensive medical system, on the planet. We spend more per capita on medicine, than really any other country, and we still have these huge disparities. By race, for individuals, and it's showing itself right now. I wish there was a great overnight fix to it, and there isn't. I mean, we, in the medical community, in the first responder community, in the public health community, we're well aware of some of the things that contribute to this, and they are not easy solutions. There's a shortage of healthcare providers in a lot of these communities. There's a shortage of culturally competent providers in a lot of these communities. And a lot of that really comes to, a lot of times people think about cultural competence in healthcare as individuals, just kind of being able to relate, to their patients, but it really goes a lot deeper than that. Even some of the subtle cultural nuances, that had to be accounted for in medical communication really come under cultural competence. When you talk about, one of the examples I give to a class of students I taught a while ago was when you tell a patient that they should exercise, that means different things to different people. When you tell a patient they should eat healthier, that means different things to different people. I always joke that, I grew up eating my grandparents' cooking, and I loved every minute of it. Looking back on it, it was probably some of the most unhealthy things I could have eaten. But it's not like it's not like we didn't eat vegetables. Like we always ate greens, but it was it's greens with a ton of salt, and and then hog log in there. So it's like, just telling somebody to eat vegetables, like, well, I eat vegetables. I ate a plate of greens yesterday.
Right.
So that cultural competence comes in with really being deliberate and understanding the communities that you're speaking to, and understanding how to translate medical guidance to those communities. And even in this particular pandemic, when you talk about cultural competence, if you're going to talk about isolation, you have to understand what the average size household is. You have to understand what normal social gathering is, even for somebody inside of the home. We have to understand that a lot of times we have intergenerational homes. So we do have grandparents who are staying with their children, who may be staying with a grandchild, who may be providing care for that young child. And they really need to understand that, those individuals who are out in the public because they're still essential workers, or who are working jobs because they need to still, pay bills and make rent. They can't work from home. They may be using an older adult as a caregiver. And I'll be honest, there's no grandparent in the world who doesn't love up on their grandkids when they see them. I think, my grandmother is, she's pushing on 90 years old. She lives a mile and a quarter away from me. I haven't seen her in 2 weeks. And there's no part of my being that doesn't give her a hug and a kiss whenever I see her. Really understanding that that's a part of of communities of color is really, really essential. And like I said, that's where that cultural competence of that healthcare provider comes into play. And like I said, even now, especially now, that's hugely important. Understanding that healthcare providers, when they're having somebody that has a positive test, we're sending them home, home for a 14-day, quarantine, especially for a younger person who's going to be healthier, who will most likely resolve, having them really realize that, some of the dangers that they pose, or a lot of the danger that they pose for death is to the older people in their lives.
That's true.
Who they may be in contact with. This is one of those unique situations where, the life you save is going to be an older person who you may or may not know. And that's what, that's where a lot of the increased risk for death comes from. It's in those older populations who have those comorbidities.
Right. You make a lot of great points there, and what comes to my mind is you're talking about the intergenerational dynamic of a household. And, a lot of people don't have the luxury where they can do work from home. They have to go out, and say they don't have a car. They have to use public transportation. The risk factors increase as they go about their day, and then they come home, and then they interact with their elderly relatives, and the potential is there. I want to ask you something else, though. When on election day, and as I'm looking at the TV, because I did vote absentee, mail in, but I saw those long lines. Some of them were trying to do the distancing 6 feet, but a lot of them were not. And I just thought, wow, I wonder, as Chief Deputy Joshua Parish is looking at some of that, what's going through his mind as he's seeing all of this, all of these people together. I mean, It's like, oh my gosh, what is this?
So what's going through my mind is, and this is the I turn on my public health brain.
Right.
So incubation period is 2 to 10 days. So it's like, and what I've, I gave a quick little like virology primer, to some of our staff here. And I said, okay, this isn't Ebola. This isn't a zombie movie. Your patients who are contagious don't look any different. we have a lot of patients in this, in this particular pandemic who are contagious and will be what we call asymptomatic. So they won't show any symptoms at all. So when you get that many people together, the odds of having somebody that is asymptomatic increase exponentially. I mean, like it's, you put thousands of people together, math just says somebody there is going to be asymptomatic and is going to be a carrier. You put that many people together, math says that, not great things are going to happen. I hope that, and I know that the election commission, who, does a great job, we're trying to really ensure that, government as a whole is trying to really ensure that the things that need to continue to happen. And, people like, election workers and, teachers who are trying to remote teach. Hats off to them because the way that they've had to change and adapt to try to think about how to go forward. This has been amazing. As far as the in-person voting thing, we will have to wait and see, what effect that had, on our rates here.
So at this point, are you kind of looking at that incubation period or that time frame to see if there might be a jump because of this?
Yep, I think everybody is watching it, and it's one where it's a double-edged sword. Everybody's hoping that social distancing, for that particular instance, worked. But the caveat is that you won't know if it was a problem until weeks later. And that's that's the unfortunate thing. Understanding how the virus works and how it grows and multiplies. No one's gonna show up at in-person voting. Touch another person and then be symptomatic before they leave the line. So you need that time spent in there, for that virus to materialize. And then kind of thinking, further down the line, for a young healthy person, they will progress through that illness very differently than an older healthy person, who will progress that illness very differently than a person who has any of those additional risk factors, any of those comorbidities we talked about.
Right.
And those are all different pools of people that that you have to be considerate of, in this. And like you said, it was difficult because there was a ton of confusion around voting. And especially, and I can speak, for my grandmother, who was born in the 30s, like she's never not voted, like literally grew up like fighting to vote, and her parents, ensured that, that she understood how valuable that right was. So, for some people it's like, well, you missed a primary. And it's like, for her, it's like, no, like you don't understand, like, her, like she grew up in apartheid Mississippi. So it's a very different thing for people from that generation. I can only imagine the struggle to not be able to do something
Commitment.
you literally put people die for.
Yeah, absolutely. So we're getting close to the end of this, but I just want to talk about a little bit. How do you think we're doing as far as, doing the safer at home, doing the mask, doing the distancing? Do you think the majority of us really get it and we're really doing what we're supposed to? Or do you think that there is still a large number of people who have not bought in to the necessity of protecting themselves?
That's a great question. From my opinion, I think that a big part of the narrative that's missing is, I think that for the most part, people think about themselves, I'm healthy, I'm gonna be fine. Because in the United States, we are very like, worry about self. I remember my grandma told me, worry about yourself. And this ain't that. This is really, you wearing a mask is protecting somebody else. You're protecting somebody that you don't know, who is going to come, who's going to come to the grocery store an hour after you and is going to, pick up, the box of Cheerios that you put down. That's really, and that's a hard thought, to get through. And even, a lot of our safety messaging, it's about, we even say personal protective equipment. When we wear gowns, it's actually to protect, it's, part of it is to protect us because, we don't want to get particulate, back on our face, later on our clothes. But a lot of it is to protect you from that next patient encounter. So I think, a big part of the messaging that I think a lot of it falls apart is like, it's being altruistic. It's saying, you're protecting my grandmother who I haven't seen in 6 weeks for, the one time when, she's going to go to the front porch and get the Amazon box. I don't know. I mean, but that's that's really the people that we're, where we're seeing those increased deaths are in those communities, and a lot of times, when you think about it, even for those wings in those hospitals, those are isolation wings. They aren't, places where, where you're going to have like the big family huddle around grandma during, her last few days. That's not a thing anymore, so, I mean, really, having that thought, and then thinking that out, my mother-in-law passed, she passed last December, and there were, and it's already like the world's smallest hospital room, and there's 14 people in this room, there's like kids on top of people's laps, as we're sitting there and saying our goodbyes. That's not an option anymore.
That's not. New normal. We are all in this together.
Yep.
And that's the way it is. Well, we've run out of time. Chief Deputy Joshua Parish, thank you so much because just in case I did mention this, he is at work. You're working right now. And again, you haven't had a day off in like a month. So we are hoping that this thing, dies down and goes away so you can enjoy life and we can get back to our lives that we used to know. But thank you so much for sharing all that you have and, giving us a little bit more of the perspective from the fire department of what you guys are enduring. And I would be remiss if I did not say that I thank you. I thank you for what you're doing. I thank all of the first responders who are out there putting their lives on the line for us. We really appreciate it. Thank you much.
Thank you for that opportunity. I just kind of want to say too, one thing that I was very deliberate about early on is that the media has a huge part in this, in this particular pandemic, because that's where people get most of their information from. So the need to distribute accurate information, once again, in a culturally competent way that people both understand, relate to, appreciate, and absorb, is huge in this situation. So I really thank you for taking the time to to give people an accurate view of what they should be doing, what this looks like for them, and how they can protect their loved ones.
My pleasure. Thank you. Have a great day. Go back to doing what you're doing because I know you have a lot to do and enjoy your day.
Thank you. Bye.
That is, again, Josh Parish, Chief Deputy of the Emergency Medical Services for the Milwaukee Fire Department. Thank you for all listening in, joining us for another edition of the 411 Live. Real people, real talk. We normally focus on human trafficking, specifically sex trafficking. That has been our mission, to bring awareness to that and increase the discussion about that. But the coronavirus just kind of rose to the top, and we've deviated from that for this for a brief period. Again, thank you for joining us. You can see our previous podcasts on any podcast platform that you have. Apple Podcast. You can go to a host of different platforms, and I'm trying to think of all of them, but you know them. And of course, we're on YouTube as well. And if you go there, please subscribe because we really appreciate that. And you can also go to our website, the411live.org. That's where you will also see our previous episodes. And if you are so inclined to contribute, because we are a nonprofit organization, you can do that there as well. For now, this is the 411 Live. Real people, real talk. I'm Beverly Taylor. Thanks for joining us, and please stay safe.